pleasure being in this arena, and it is really interesting to see the newer developments. We have a very interesting speakers and who have well established, started their careers in open surgery, then went on to laparoscopy, and then went on to robotics, and then have switched over to HIFU, and then they will be able to share all their experiences about the system. We will begin the program with our first talk on uterine fibroids and adenomyosis and its impact in assisted reproduction. Patrick Steptoe and Robert Edwards performed the scientific feat on 25th July 1978. We have come over about 44 years now. A lot of improvements have taken place since then. We have developed ICSI, IMSI, PICSI, assisted hatching, PGS, PGD, you name, right up to the artificial intelligence, we have developed them. But the success rate has not increased significantly. What was there at 20, probably around 30. We have some troubled areas like endometriosis, fibroids, adenomyosis, for which we do not have a very clear answer yet. In the picture here, you will see Robert Edward along with the mother of Louis Brown, and Louis Brown carrying her own. That the second generation has just come back. Now let's look at the results of an IVF program. It depends upon the age of the patient, ovarian reserve, male factor, stage of the transferring embryo, uterine environment, luteal support, and absence of additional risk factor. All of them contribute to the results of an IVF. What we say is about a limited, say 30 or 35, we try to push the patient into that particular arena by eliminating all these things. Now let us focus on the uterine factor. This is on the size and shape of the uterine cavity, endometrial lining, endometrial blood flow, myometrial support, fibroids, and adenomyosis. All of them put together is contributing to this particular. Now, if you start with fibroids, we know that the incidence of fibroid is about 25 to 30%. So if so, there is some increased incidence in ART about which we will see. So what are all the options available? We have some medical methods of managing a fibroid. And then we have surgical methods like open myomectomy, laparoscopic, robotic, and there are a lot of newer advances has come about which we have eminent experts who will be waiting to talk to us about it. But overall, what we plan is a stimulation, ovum pickup, and freezing of the embryos, followed by management of the fibroids prior to the embryo transfer. Because surgery, to a certain extent, can impinge on the ovarian reserve. And that is the reason we try to do the pickup and then plan for the surgical treatment of the fibroids prior to the surgery. But here, what are all the problems in the management? One is the cost of the treatment of the fibroids and adenomyosis. The most importantly, the aftermath of the treatment, that is the scarring of the cavity and decreased vascularity in the cavity. Time taken to heal to be ready for an embryo transfer, and patients' emotional stress, and then again worried about the results of the embryo transfer and treatment of the fibroids and adenomyosis. How does this infertility and myoma thing interrelate? So this is controversial, mainly because it is difficult to prove the causal relationship. There are about 70 to 80 studies indicate the pregnancy rate is about 50% after the myomectomy in infertile patients. But there are no well-controlled randomized studies, no clear description of the size and number and location of the fibroid, and no standardization of the diagnostic methods with different outcome parameters. The results, as per the Jacques-Donnay studies, varies right from 10% up to 70%. So it is more commonly seen in IVF patients. Why? Mainly because there is a delay in childbearing when the fibroids are more common. So when they become a little bit older, the fibroids become more common. And, as the age advances, the fertility decreases. The woman who is scheduled for a simpler procedure lands up with an IVF. So this is the reason why we get to mosaic. How does this myoma impact on infertility? There is an encroachment of the tubal ostium and occlusion. There is a distortion of the uterine cavity. Some vascular changes interfere with the normal rhythmic uterine contraction, impaired implantation, abnormal endometrial maturation, altered to oxytocinase activity. All of them contribute to this impact on infertility. You see, there will be a small cavities, what is shown here in the slide. There will be a small cavity, something like what we call it as a caviole in the host endometrium, myometrium. So if there is a fibromyomata, they are decreased when compared to the normal myometra. What is the problem? So when there is a specific structural abnormality, it may result in calcium metabolism by causing a decrease in defect calcium excretion. So what actually happens? There is a rise in intracellular calcium. If there is a rise in intracellular calcium, it produces myometrial irritability and hyperactivity. So it results in the disruption of the rhythmic contraction process in the junctional zone. So there is a reduced contractile pressure in the fibromyomata, which increases following the myomectomy. These are all the mechanisms there. If there is a subendometrial tumors causing endometrial erosion and subsequent inflammation, altering the nature of the intrauterine fluid, resulting in an old-style environment. They might disrupt the endometrial blood supply, affecting the nadation and then the sustenance of the embryo. The other major problem will be an adenomyosis. It is an enigma or a nightmare for the ART clinician. Treatment, just like how we deal with the fibroid, medical management, surgical, were open, laparoscopic, and robotic. Then came the MRI-focused ultrasound, and now we have an HIFU. So about which we are going to just have a detailed talk. But here again, the plan will be the stimulation and OM pickup with freezing of the embryos, followed by management of adenomyosis prior to the embryo transfer. So you look at the outer myometrium, then you have an inner myometrium, and then there is a junctional zone. This junctional zone is very important entity in the reproduction. And ontogenically, it is related to the endometrium. There are some cyclical changes in the SSH receptors there. It has a very important role in the gamete transport and implantation. And there is some early changes from the time of implantation. Deserialization and trophoblast invasion happens here is very, very important. If it is defective, then probably it results in a spectrum of pregnancy complications like abruptio placenta and abnormal placentation there. This is just to show you the junctional zone, how it appears in different areas. And this is for you to schematically identify. This is a normal junctional zone. And here there is a global adenomyosis. Throughout, there is a uniform thickening of the junctional zone, which is seen by an MRI here. And here you will see in only one area, this is a focal adenomyosis, where you will be able to make it out in an MRI. So these are all different varieties of adenomyosis which we can know. Now we will see the impact of myoma on infertility. So Jacques Donné's studies, he has seen it, one arm on control, other arm, there is a fibroid with no cavity destruction. And the other side, there is a cavity destructed cavity. You will see in almost all the studies, when compared to the normal, the pregnancy rates has been lesser in no distortion, and it is still lower in the distortion cavity uniformly in all the studies. There is another study by Pritz in 2001 in Obstetric and Gynecological Survey. He has taken about 3 prospective controlled and 8 retrospective control studies, but there is no randomization. Women with otherwise unexplained infertility, location of the fibroids related to the pregnancy, implantation, and deliveries were not calculated there. So in this, the odds ratio for pregnancy is about 0.32 here, with an implantation of 0.2. The same way, after the resection, you will see that it increases to 1.7, implantation increases to 0.9. That shows its result of the myomectomy there. So on conclusion of that FRITZ study, subserosal fibroids do not affect the fertility or spontaneous abortion rate. Submucous fibroids lower fertility rates, and myomectomy enhances the rate of conception and live birth. Intramural myoma with or without distortion of the cavity may cause detrimental effect on conception, reaching viability with pregnancy, and effect of the myomectomy is unclear. See, there are conflicting studies here. If you take a submucous fibroid, you will see that in the top study, where it is 3% implantation rate, and the clinical pregnancy rate is 14%, which is much lower. And then there is a spontaneous abortion rate is about 46.7. But whereas there is two studies which I have just quoted here. One says summary of the studies of the IVF model shows that patients with fibroid distorting the cavity have impaired implantation and pregnancy rate. Whereas in the other Taylor study, which shows submucous myoma has a global decrease in the endometrial HOX gene expression, a molecule marker for endometrial receptivity. That is a reason why it should come back. If you take in intramural fibroid, is it a misnomer? It may be classified as an outer myometrium or junctional zone fibroids there. What about its impact on the intramural myoma? There is a plausible mechanism for these fibroids not distorting the cavity has been seen there. However, there is a study by Hart et al. In 2006, and they have just said intramural negatively affects IVF results. However, you will see Inc. study here in Human Reproduction 2002, intramural fibroids do not affect the IVF study. There are a lot of conflicts there. So the impact when the fibroid is more than 5 centimeters, the implantation dropped from 20 to 11. Ongoing pregnancy rate dropped from 34 to 23. And the pregnancy rate overall dropped from 28 to 15%. So large intramural fibroid negatively affects a pregnancy outcome after an IVF. Large intramural should be removed before IVF. So again, it is beneficial in patients with IVF, but that does not necessarily mean myomectomy should be performed systematically in women trying to conceive, not needing an IVF because of the risk of adhesion formation and myomectomy. So this is not a blanket rule to operate on it. And what about the fibroids which are smaller than 5 centimeters? Should they be disregarded? Should we be operated before IVF? Should we operate after the IVF failure? And if so, after how many failures? Or do we operate before any infertility treatment at all? So all of them are queries. Should the decision be influenced according to the cost of the IVF in different countries? Higher the money you pay, you go through all these minor things, correct it, and then come back there. So if it is an intramural fibroid smaller than 5 centimeters, checks reported there is no difference in the implantation rates and pregnancy rates, but they find a lower delivery rate and a higher rate of miscarriages. However, Oliveira studies, which has been published in Fertility Study 2004, no effect on pregnancy rates and no higher incidence of miscarriages. But however, he has just taken only one cycle there. So here in the Calaf studies, which has been published in Human Reproduction, you will see if it is less than 5 centimeters, when compared to the control of 32.9, the pregnancy rate has dropped down to 23, and live birth from 24 has dropped down to 14.8. If you see, there is a 40% reduction of success rate in each cycle as they go from cycle to cycle, and if there is an intramural fibroid. So again, if you analyze this, 75 patients with myoma and 127 patients without myoma. So the clinical pregnancy rate is 45 when compared to 53 without myoma. Implantation is 48 when compared to 63 without myoma. And there you will see that then abortion rate is about 40% against 18.9% said. So there is a poor implantation, poor clinical pregnancy, and increased rate of abortion in this myomas there. Here again, you see the number of myomas. If there are less than 3 myomas, the clinical pregnancy rate is about 35. But if it becomes more than 3 myomas, it results in 28.6%. However, the control is about 41%. And you will see the abortions again, 34.3% if there is less than 3 myomas. If it is more than 3 myomas, it goes as high as about 60% there against the control of about 10. So the pregnancy rate after an IVF in an intramural myoma with various authors, they have just shown it. Definitely, it comes down from the control appreciably there. So these are all the different studies where there is an increase in miscarriage rate after an IVF and if there is an intramural myoma. But what about the impact of the myomectomy and infertility? If you do a laparoscopy, about 51% of them have been with the addition and 30% has been just with an adnexal addition. However, and the laparotomy, there is an increased incidence when compared to laparoscopy on this, according to Dubison study, which has been published in Human Reproduction Update. If you look at the pregnancies after a myoma, so they have taken about 2,065 singleton and compared with the randomly matched birth year and no match for age, parity, and race and term thing. Here, there is an increase in odd ratio for abruptio, first trimester bleeding, and dysfunctional labor, breech presentation, and cesarean delivery. So, in an Israeli population-based study, again, the cesarean rates odds ratio is about 6.7, placental abruptio is 2.6, and prematurity is about 1.34. So, to conclude on this, despite the lack of randomized studies, sharp decline in the pregnancy rates in the submucous myoma is quite convincing, and myomectomy should be performed before ART. It decreases the clinical pregnancy rate, implantation rate, and live birth, and increases the abortion rate. If it is an intramural myoma, it is more controversial, lack of homogeneous opinion, decreased fertility, increased pregnancy loss, and the effect of myomectomy is still questionable. But the consciousness is if there is a myoma of more than 5, advised to operate before ART. If it is less than 5, report outcome varies with no difference, significantly decreased cumulative pregnancy rates there. The controversial final conclusion are probably mainly because of the difference in investigation between the different studies, lack of properly performed investigation, need for a good standardization, evaluation related to distance to and then involvement of the junctional zone, in this case of fibroid, and need to randomize the studies there. So, but if you consider the obstetric outcome, definitely there is an increase in the abruptio placenta, breech presentation, cesarean section, and preterm delivery. And thank you very much for a patient listening. This is with the background, we move on to see how we deal with the fibroid and then how we manage it.